we get into the case, thereafter we'll also discuss the case in detail. So Dr. Mwemba, please take over.
Thank you so much. I had requested that you share the slides for me.
No problem, we'll share from our end. Can you see my screen?
Yes, I can, thank you.
All right.
So good afternoon. I have no disclosures to make. So this afternoon we'll be looking at HIV and non-communicable diseases, integration, and why integrate. Next slide, please. So we'll discuss the relationship between NCDs and HIV, and then we'll look at the burden of NCDs among people living with HIV. We'll discuss the integration of NCDs in HIV services in Zambia. And if we have enough time, maybe I'll just discuss the general principles of management of common NCDs among people living with HIV. So this slide is just illustrating that because of ART, mortality has reduced and there's increasing lifespan. On the upper right panel, you can see that now that a person living without HIV, probably they have a life expectancy of about 79. If you are diagnosed with HIV and you start taking medication at age 20, probably your lifespan would go up to 71 years. If you are 20 years and HIV and you're not on the medication, probably will just go up to 32 years. I think what I wanted to emphasize here is that you can see that even an individual that is on ART, despite age being, a lifespan being increased, there's still a gap of about 6 to 10 years there. And that gap is probably most likely, and we know is due to non-communicable diseases. And therefore, we have the fourth 90. And the fourth 90 is that we need to have people living with HIV to live health aging for people living with HIV. Next.
Welcome to the first poll question. So the first poll question reads, why are NCDs common in people living with HIV? Why are non-communicable diseases common in people living with HIV? The poll has been launched. We can start to poll. A, HIV infection induces a chronic inflammatory state even when virally suppressed. B, the cohort of people living with HIV is aging. Some drugs used in the treatment of HIV cause NCDs. These include the protease inhibitors, the integrase strand inhibitors, as well as the nucleotide reverse transcriptase inhibitors such as tenofovir or the above. I'll read that again. Why are NCDs common in people living with HIV? Is it A, HIV infection induces a chronic inflammatory state even when virally suppressed? This is a single best answer. The cohort of people living with HIV is aging. Some drugs used in the treatment of HIV cause NCDs, including the PIs, the INSTIs, and NRTIs, or the above. We have about 20 seconds to go to poll. So far, only 45% of the participants have polled. We are getting there. Let's keep polling. So why are NCDs common in people living with HIV? Is it that the HIV infection induces a chronic inflammatory state, even when virally suppressed? Or is it that the cohort of people living with HIV is aging? Or is it that some drugs used in the treatment of HIV cause NCDs, including the PIs, NCDs, or NRTIs? Or is it all the above? So far, over 60% of people have polled. We'll end the poll in about 10 seconds. All right, so we'll share the results. As you can see, the majority of people think that it's all the above. From the people that polled, over 50% think that D is the answer. There's a good number of people who think that some drugs used in the treatment of HIV cause NCDs, and another good number that think that A is the answer. So we'll hear from Dr. Mwemba.
Yeah, so thank you so much. I think that we know from my initial opening remarks that the advent of ART has actually improved life expectancy. And so HIV is no longer a fatal disease, it's now a chronic disease. We know that NCDs are chronic conditions that do not result from any infection. And hence that's why we call them non-communicable. They are diseases that have a prolonged course that do not resolve spontaneously, and for which a complete cure is rarely achieved. NCDs are common in HIV individuals, and this is partly due to HIV infection inducing a chronic inflammatory state even when virally suppressed. We know that despite ART is that there's some immune process that goes on into the body, and that can lead to NCDs. And because of good ART, we know that the people living with HIV now are aging. And so age itself means that NCDs will also increase in number. Some of the drugs we use for the treatment can cause NCDs and include across all the classes that we use, including in Zambia. What are the characteristics of NCDs? They are complex. They have a complex etiology. They have multiple risk factors. They have a long latence period. And they are non-communicable, meaning that they are non-contagious, and they have a prolonged course of illness, but they can lead to functional impairment or disability. There are types of NCDs, which we all know, and these include cardiovascular disease that can include coronary heart disease, stroke, peripheral vascular disease. We have got cancers, we have got chronic respiratory disease, diabetes, mental illness, epilepsy, and chronic neurological disorders like Alzheimer's or dementias, musculoskeletal diseases like arthritis, and sometimes non-intentional injuries from traffic accidents. The focus for our HIV NCD integration in Zambia is mainly on hypertension, diabetes, and obesity and dyslipidemia. This slide is just trying to show what has been studied already in Zambia. And this was a step survey that was done in 2017. And what it shows is that we have a good proportion of individuals that have not been screened for cervical cancer, for example, among women. Physical inactivity is one of the things that was found, and obesity and increased BMIs, and hypertension is common among our population. Next. So there is a hypertension prevalence among persons living with HIV. And this was a study that was done between July 2020 to June 2021. and it involved our national electronic health record system. Next. And basically is that we know that stroke is the second most common cause of death in Zambia. And hypertension is a major risk for stroke. And it's estimated that probably in Africa, the prevalence of hypertension is around 16%, might be higher, especially in people living with HIV, and we have documented up to 25% in one of the meta-analyses. Obviously, in Zambia, there's limited data, and we are not sure of the people living with HIV, what the prevalence. We know that there was a prevalence that is estimated at 6.4%, and half of these are undiagnosed. And it seems that a quarter of these probably are reported to have had a stroke or MI, and from the previous studies that were looked at in Zambia. Next. And so we looked at the smart care electronic data to find out if we could see how much we do with NCDs, and in this case, it has to do with hypertension. As you know, that the National Electronic Health Record System for HIV has been there since the early 2000s, and it has a number of modules in the system, and a number of so many facilities, more than 1,500 nationally use this data. And we know that 80 to 90% of people living with HIV are in this smart care. Next. So what were the findings? The findings are actually that hypertension is quite prevalent. 14.5% when you use when you looked at data for individuals that had measurements above more than 2 measurements and were recorded. And stage 2 hypertension, which in this particular case was defined as BP more than 160/90 for individuals that had hypertension only once, was like 63.5%. So this shows us that actually hypertension probably is very common among people living with HIV, even within our cohort of HIV individuals. Next. It seems that age and sex were determinants. So males, 16.7% versus females was higher among males, and age was a factor. For example, for individuals that were above 60 years old, hypertension was like more than 35% for hypertension prevalence. And for stage 2 hypertension, it was 73%. So you can see that age is a factor and males seems to be more affected. Next. When you look at geographical distribution, hypertension obviously varied from province, 5.6 in Muchinga and 16.3 in Lusaka, and urban areas seem to be more affected, 16.3 in Lusaka versus 9.1 in the rural areas. Next. Body mass index was also a factor that seems, and hypertension prevalence increases with people living with HIV who are overweight. And this was dose related. And you can see on the panel above there that as your BMI increases, the higher the chances that you'll have hypertension. Next. Renal dysfunction also. I should mention here that 86% of the observations, creatinine data was missing, but the prevalence of elevated creatinine was higher among individuals that were HIV with hypertension. And just to re-emphasize that hypertension, male sex, and old age all were associated with elevated creatinine, meaning renal dysfunction. Next. The limitations, obviously, to the study was that the sample was not representative of all people living with HIV in Zambia, and the data was not very complete, and there was a skewness towards the provinces that were using IFE sites, which is Lusaka and Southern Province. And it only looked at 1 year period. And so those were the limitation of this study. Next.
Thank you so far. The second poll question, let's get ready to poll. The second poll question reads, according to WHO, the World Health Organization, which one of the following is not prioritized as a modifiable risk factor for non-communicable diseases? According to WHO, which one of the following is not prioritized as a modifiable risk factor for NCDs? The poll has been launched. A, is it physical inactivity? B, is it tobacco use? C, is it alcohol use? D, unhealthy diets? Or E, family history? Let's get polling. We have just about 30 to 40 seconds to poll. According to WHO, which one of the following is not prioritized as a modifiable risk factor for NCDs? Is it physical inactivity? Is it tobacco use? Is it alcohol use? Is it unhealthy diets? Or indeed, is it family history? So far, just about 40% have polled. Let's continue polling. This is the single best answer. We have 10 seconds to go. According to WHO, which one of the following is not prioritized as a modifiable risk factor for NCDs? Physical inactivity, tobacco use, alcohol use, unhealthy diets, or family history? Just about 60% have polled. We'll end the poll at this point and we'll share the results. So from the results, we can see that the majority think that family history is not prioritized as a modifiable risk factor for NCDs. A good number also think physical inactivity is an answer, with a small number thinking unhealthy diets, alcohol use, or tobacco use. So we'll continue hearing from Dr. Mwemba and we'll get the answers. Dr. Mwemba, you can continue with the presentation.
Sorry, I couldn't see the slides. I can see them now. Thank you. So what is the risk? So a risk factor is an aspect of a personal behavior or lifestyle, an environmental exposure or a hereditary characteristic that is associated with an increase in the occurrence of a particular disease, injury, or other health condition. A behavioral risk factor that can be reduced or controlled by intervention, thereby reducing the probability of disease, is called a modifiable risk factor. And WHO has prioritized 4 of them: physical inactivity, tobacco use, alcohol use, and health diets. A non-modifiable risk factor is a factor that cannot be reduced or controlled by intervention. For example, age, gender, race, or family history.
The third poll question, we're on the third poll question. The following are common risk factors for NCDs. The following are common risk factors for NCDs: tobacco use, unhealthy habits, physical inactivity, and harmful use of alcohol. This is a true or false question. You are either here or there. The following are common risk factors for NCDs: tobacco use, unhealthy habits, physical inactivity, and harmful use of alcohol. Can we launch the poll question? The poll question has been launched. We can start polling. The following are common risk factors for NCDs: tobacco use, unhealthy habits, physical inactivity, and harmful use of alcohol. True or false? The answers are coming in real fast. So over 60% have polled. Interesting. We'll end the poll here and share the results. So the overwhelming majority, 99%, overwhelming majority, 99%, think that the answer is true. Wow, just about 1% think that the answer is false. Dr. Mwemba, you can continue the presentation. Thank you.
Thank you. Actually, that was a repeat question to just see whether people were following. And that was just to illustrate that of the 4 diseases, cardiovascular disease, diabetes, cancer, and chronic respiratory, you can see that actually they share these 4 common risk factors: tobacco, unhealthy diets, physical inactivity, and harmful use of alcohol. And you can see that cardiovascular disease, diabetes, and cancer share all the 4. Chronic disease, respiratory has 1, but actually when you critically think about it, maybe all of them do contribute also to chronic respiratory disease as well. And these 4 account for over 80% of all NCD burden. A metabolic refers to the biochemical processes involved in the body's normal function. Behaviors, which we have already said are modifiable risk factors, can lead to metabolic physiological changes. WHO again has prioritized 4 metabolic risk factors, which are raised blood pressure, raised total cholesterol, elevated glucose, overweight, and obesity. This pyramid here just shows where the risk starts from. So it starts from social determinants of health, which include globalization, urbanization, an aging population, just like in our HIV population. And then the 4 risk factors that we have already described. And then those 4 risk factors can lead to those metabolic issues that can come about, which are increased blood pressure, overweight, raised blood pressure, glucose, and raised lipids, which then lead to NCDs. Next. So there's what we call primary prevention of NCDs, which is just, it can be done at an individual level or societal level. Examples at societal level include the policies made by government to just promote smoking cessation, to promote health diets, to promote physical activity, and to prevent alcohol abuse. And usually this is through laws that are made by government. At an individual level, one can include health promotion measure to enhance physical activity, good diets, and smoke cessation. Secondary prevention, on the other hand, is early identification of risks and linkage to appropriate treatment. So you screen for NCDs in people living with HIV, and so you screen for hypertension, for diabetes, for high lipids, and for obesity, and then whoever is identified, then they are linked to care, and then you continue them so that they don't get all the complications of NCDs.
Okay, we are now on the 4th poll question, and things are getting really warmed up. So the fourth poll question is also a true or false question. It reads, NCDs are more common in HIV infection than non-HIV infection due to the following: chronic inflammation due to HIV or opportunistic infections, drug use in the treatment of HIV, age, psychosocial effects of HIV, and biological effects of HIV. We can launch the poll question meanwhile. NCDs are more common in HIV infection than non-HIV infection due to the following: chronic inflammation due to HIV or opportunistic infections, drug use in the treatment of HIV, age, psychosocial effects of HIV, and biological effects of HIV. This is a true or false question. Please, let's pause. We have about 20 seconds to go. We've just crossed the 50% mark in terms of polling. Let's continue to poll. Okay, we have just over 60% that have polled. So we'll end the poll here and discuss. So as you can see, the majority think that the answer is true, while about 18% of people think that this is false. Dr. Mwemba.
Thank you. So HIV and NCDs. NCDs are common in HIV infection than non-HIV infection due to the following reasons. Chronic inflammation due to HIV or opportunistic infections, the drugs that we use in the treatment of HIV, population, the aging population, psychosocial effect of HIV, biological effects of HIV, such as increased gut bacterial translocation and change in the gut microbiota. It is also important to mention that ART and viral suppression are important in reducing NCDs in HIV, as you can see that OIs can enhance opportunistic infections. This is just interaction between NCDs and HIV. So HIV infection can lead to NCDs. Biological factors can lead to NCDs. Psychological effects of HIV can lead to NCDs. And obviously, they are normal human beings, so they can have also genetic factors that can lead to NCDs. What is the integration of HIV and NCD services? It is the provision of HIV and chronic NCD disease services at the same time, by the same person, and in the same place. This should include the integration of health systems of HIV and NCD, including supply chain, commodities, healthcare finance, and health informatics. What are the types or areas where we can integrate NCD HIV services? So we can integrate services at the point of registry. So you will synchronize NCD and ART appointments. We collate ART and NCD files. At the triage level, we can do measurements of BPs, sugar, heights, and BMI for those that need attention. In the counseling rooms, we can do, always we can do lifestyle messages in the counseling, which include smoking cessation, harmful use of alcohol, health diets, and physical inactivity. In the clinicians' rooms, we can check for signs and symptoms, NCDs, or their risks. We can monitor for response in those that are on treatment, and we can also do lifestyle counseling at this stage. In the bleeding areas, we can also collect blood for monitoring of NCDs or diagnosing NCDs. Whereas in pharmacy, we need to ensure commodity security for NCD conditions and dispensation of NCD medications to our clients. So in other words, NCDs must be integrated in all service points in the ART clinic. What are the advantages of NCD HIV service integration? It's a real example of person-centered care, leveraging on our resources that we already have. and synergizing on innovations such as the lessons that we have learned during the scale-up of ART. And in the general, it will improve quality of care and sustainability of the innovations that we are creating. I've already shown this slide that through NCD and HIV integration model, we can do NCD primary and secondary prevention services must be provided where ART services are provided. And I'm not going to go in detail on this slide because I've already discussed it. NCD models among people living with HIV. So individuals with well-controlled NCDs and HIV can be enrolled in our DSD models for stable clients. It is encouraged that these models must synchronize with the models for ART pickup services. Those with uncontrolled NCDs, such as advanced NCDs, can also be seen by specialized DSD models, preferably by specialists care. Down here, I have examples of the DSD models for NCDs, and I'm not going to go into the details, but I think we'll share some of these slides so that you can just see. So facility-based model which we incorporate both NCD and ART, such as fast-track drug refills, after-hours refills, weekend refills, and other specialized support can also happen for NCDs. Integrating ART-specific DSD models, such as multi-month dispensation, 6 months refills, and community ART dispensation with a dispensation of medicines for NCD. So those 6 months refills, we can also include NCD medications as well. Community health posts which provides NCD and ART care can also provide for NCDs. The community adherence groups for ART can also provide for NCDs. Next. This is just a diagram trying to show integration of HIV NCD services. So you have the HIV population there being screened for blood pressure, for glucose, for BMI, for lipid profiles, and kidney disease. And at the end of the day, these conditions can be diagnosed. Once you diagnose, then you need to answer whether they have a condition or they don't have a condition. Depending whether they have a condition, then they can be followed up in an NCD HIV treatment can be monitored going forward. Next. So, so we have other surveys that have been done just to see how we can integrate and what is lacking in terms of NCD care in the ART clinics. So there was an in-depth interview with clinicians for this survey that happened in all the 10 provinces. And in those provinces, 3 districts were picked and 3 selected facilities were sampled. Data entry and analysis were done using RedCap. Next. And the summary of the findings were that most ART centers, clinicians are nurses or clinical officers, and knowledge that integration was present. So integration between HIV care and NCD was present, but clinicians had a lot of barriers. There were some best practices, but most of them were disjointed. Commodity, laboratory, and M&E challenges were potential issues that needed to be resolved for the clinicians to be able to integrate NCD and HIV care. Next. So what are the next steps in the integration? A concurrent dual implementation approach where one, have some demonstration sites, those that have active DSD and intense management. And then later on, secondly, then we roll out to the nationwide so that we all start to integrate NCDs in our ART clinics. It is also important that we coordinate with other efforts and activities being implemented by other stakeholders, and other stakeholders have been brought on board to just help in this. So far, there has been some achievements. So baseline site monitoring has been done and TSC has been done. Materials have been developed and implementation meetings have already been developed. Obviously, there are challenges of lack of a full-time focal point person, and we're still not very clear of the implementation plan. These are just examples of the sites that have been picked for integration. Next. And this is just trying to help us how to choose a DSD model for NCD and HIV. And we have to answer the what, who should do it, where should it be done, and when should it be done. Next. I'm not going to go through the risks, the management of cardiovascular diseases, but I think that I'll just point out that the 4 risk factors, the modifiable risk factors, are usually general to all of them. Next. And the management of obesity, again, it has to do with diagnosing first of all. So we need to screen them, diagnose them, and then we manage them according to the protocols. And these protocols will be shared as we spread out to the whole country. Next. It applies to dyslipidemias. Next. It applies also to diabetes mellitus. I'm not going to go into the details, and we'll share the slides after when we're done. Next. We can go to the next. We can go to the concluding slides. So in summary, all I can say is that NCDs are common among HIV patients. NCD services must be integrated with HIV services by ensuring that all HIV services points provide NCD care, and it's our role to do that. DSD models for NCDs must be developed in facilities. Primary prevention, including smoke cessation, health diets, physical activity, and cessation of alcohol misuse must be provided for all people living with HIV. Early diagnosis and linkage to care and monitoring outcomes is key for secondary prevention of NCDs. And then the specific treatments for each of these, I think we'll be doing technical support so that all of us can start to manage these patients. Thank you, unless there are questions.
Thank you so much, Dr. Mwemba, for that elaborate presentation. As I said, the presentation was going to be packed, and you've seen that it is packed. As has been said, we will share the slides after this presentation, after this session, so that we can get to have a bit more detailed discussion. So we'll go quickly into the repos. Very quickly, we'll just give about 20 seconds for each question. Question 1, why are NCDs common in people living with HIV? A, HIV infection induces a chronic inflammatory state. Even when virally suppressed. B, the cohort of people living with HIV is aging. Some drugs used in the treatment of HIV cause NCDs, including the PIs, NCDs, and NRTIs, or all the above. So let's quickly poll. We have 10 seconds. Okay, I think about half the participants have polled. I'll end the poll here. So, Dr. Mwemba, as you can see, the majority believe that D is the answer. Are you able to just spend a few seconds just to explain the rationale here?
Yes, so D is the correct answer. The HIV population is aging, so that is increasing the risk of NCDs in people living with HIV. Two, like Area said, whether you are on ART, the immune system still gets activated, and therefore that leads to NCD. And three, the drugs that we use can also predispose. So yes, the answer D is the answer. All of them are true.
Okay, thank you so much. So we go straight into the second poll question. It reads, according to WHO, which one of the following is not prioritized as a modifiable risk factor for NCDs? Is it physical inactivity, tobacco use, alcohol use, unhealthy diets, or E, family history? We have about 20 seconds to poll. According to WHO, which one of the following is not prioritized as a modifiable risk factor for NCDs? A, physical inactivity, B, tobacco use, C, alcohol use, or D, unhealthy diets, or E, family history. We'll end the poll here and share the results. Dr. Mwemba, take us through this one. The majority think that family history is the answer.
Thank you so much. Yes, the majority history is the answer. We can't do anything about family history. If you are genetically predisposed to cardiovascular disease, that we can't modify. We can only modify it by the other factors that have been, the other four factors that are mentioned in that question, but not family history. We can't modify the genes, unfortunately, and that's the correct answer.
Okay, thank you. We'll go to the third poll question. Kindly launch it. The following are common risk factors for NCDs. The following are common risk factors for NCDs: tobacco use, unhealthy habits, physical inactivity, and harmful use of alcohol. This is a true or false question. Let's get polling. Okay, we'll end the poll here. Dr. Mwemba, a lot, in fact, 100% of the people that polled think that this is true.
That's very impressive. So I think that the message as we go out and we see these patients, including ourselves, is that the message should be not to smoke, to exercise, to eat healthy, and to avoid alcohol abuse. If we do that message, probably will prevent more than 80% of NCDs in our population. Thank you.
Thank you so much. Fourth poll question, it reads, fourth poll question, NCDs are more common in HIV infection than non-HIV infection due to the following reasons: chronic inflammation due to HIV or opportunistic infections, drug use in the treatment of HIV, age, psychosocial effects of HIV, and biological effects of HIV. Single best answer, true or false? Let's poll in the last few seconds. We have over 50% that have polled. We'll end the poll here. We have 97% of people that have polled think that the answer is true. Dr. Mwemba.
Thank you once again, Doc. Yes, the answer is true. It has to do with aging. It has to do with the drugs that we use. It has to do with the inflammation that is going on. And so those are the risk factors that lead to NCDs in HIV population. So the answer is yes, true.
Thank you so much, Dr. Mwemba, for that elaborate presentation. So as I said earlier, we will go into a small discussion where we'll tackle a few questions just for about maybe 5 to 10 minutes before we have a case presentation. Our experts logged in now, Dr. Sivile. Or Dr. Msiska. Just say hello to the network if you are on the call. Dr. Wilbrod Mutale. We'll begin to tackle some of the questions that are coming in. So remember, you can type in the chat box. Then you can also raise your hand if you want to ask a question directly. So use of chat box or raise your hand, and then we'll allow you to speak. Dr. Mwemba's presentation just reminded me of how sometimes patients, are shunted. If it's an ART patient who's come for maybe pickup of drugs, the diabetes drugs, hypertension drugs, sometimes we might send them to OPD to get drugs. But the message today is very clear. We need to be able to integrate these services. Our pharmacies need to stock the medication that will be able to give our NCD clients. Kelvin Chishala, are you able to unmute and go ahead?
Yes, Doc. Thank you very much. Good afternoon. My question is on one of the poll questions we had, and I think it should be question number 1 or 2, the one which was which included the viral suppression component. If I remember in the presentation in one of the notes, I think it was mentioned that virus suppression contributes to the lowering of the risk to get hypertension or any of these NCDs. So maybe just a comment on that one, the message.
Okay, thank you so much, Kelvin. Inshallah, your question has been noted. You're asking how viral suppression will lead to one having a reduced risk of NCDs. A question from Rose Chirwa is, what is in the package of NCD management in ART? This is from the chat box. What is in the package of NCD management in ART? And then we'll do a third one as well, so that then we give chance to Dr. Mwemba to respond. We have a third question.
It's a problem.
So, Dr. Mwemba, you can go ahead with those two questions. The first one
go ahead.
Is asking how, yes, viral suppression will aid in reduced risk.
Okay. So imagine that you let the virus multiply. It means that the inflammation is higher than an individual that's in an ART. So if your inflammation is reduced, it means that you are curtailing the inflammation that can cause endothelial damage to your vessels. And in such, you are reducing NCD. That's one. Secondly, as I mentioned, that OIs, including TB, including crypto, including most of the infections, can lead to NCDs. So by enhancing immunity, it means that you are reducing the risk of OIs. And therefore, when you reduce the risk of OIs, those OIs that can lead to NCDs, you are preventing that. So there's a huge benefit of individuals that are on ART and reducing NCD prevalence within those individuals. I earlier mentioned that for an individual who's 20 years old now and they get HIV, the likelihood that they will live up to 71 years is higher than an individual who's not an ART, because they can actually go only up to 32 years. Part of that reasoning is that the incidence or the prevalence of NCDs in an individual that is not on ART is very high. That's the first question.
Thank you so much, Doc.
The second question was, what is in the package for in our integration of NCDs and HIV? I'm not sure if some of the experts are here, but I know that we plan to focus on the 4 areas that I mentioned, which are hypertension, diabetes, lipidemias, and obesity, and is starting from primary prevention, where we'll be sending messages to all people living with HIV that if we focus on those 4 risk factors that I mentioned, that probably we can prevent NCDs. At the same time, we'll be screening for those conditions. We want to screen for all those conditions in all our ART sites, so that once we diagnose them, we can prevent other NCDs that can come as a result of the 4 that we have mentioned. So there will be primary prevention, secondary prevention, and tertiary prevention to make sure that we work to prevent NCDs among HIV individuals. And it will include everyone. It will include all of us, doctors, nurses, pharmacists, as you can see, IT, because we need to document also the data that we're getting. So it will be comprehensive. It's a comprehensive package that should cover everything to do with those 4 conditions that I've mentioned. I don't know if one of the experts.
Okay, thank you so much, Dr. Mwemba, for that. So we are having quite a number of questions that are coming in. So I think what we can do is, if we have some of the experts on the call, we can begin to address some of the questions in the chat box. There are quite a number of questions that have come in. I'll allow Dr. Daniel Mwamba to just quickly come in. Dr. Mwamba.
Yes. Good afternoon, Dr. Mwamba. And okay, thank you. I noted Dr. Wilbrod he's in another meeting actually. So I thought of jumping in.
Yeah, I'm available. I'm following.
Okay, maybe you can come in just on task pen issues.
Okay, so thank you, team. Dr. Mwemba, thanks for emphasizing the issue of integration. As a health system expert, this is the language we want to hear, that we are dealing with the same patient, and that same patient would come with different conditions. And so it's not fair to split the patient because we have segregated the services. So the issue of integration is key, but also recognizing that some people are overburdened than others. Thinking about hypertension, we know in the general population, especially in Zambia, it's about 20% in non-HIV, but in HIV, it can actually double. A smaller study which was done showed almost like 44% of the people with the HIV also had hypertension. Different studies have shown different numbers, and we are going to do a national survey with Dr. Seville and the team. We are just preparing with Global Fund, Dr. Henry Piri, to actually establish how big a problem is at national level. But from the work that people do and everyday work, we know this is a big thing. So what we did was to put a study to NIH, which is the National Institute of Health in the US, to fund a study to work in Lusaka mainly to try and pilot an integration of NCDs into HIV care and use these lessons to share with the ministry to expand. So we developed the guidelines, we did the training, and we are focusing on non-physician health workers, knowing this is the largest group providing the services like Dr. Mwemba and the team have shown. And so we are providing training to these groups. And so what we started was a pilot in George Clinic and also in Chilenge. And now we are moving into the next phase to have other clinics in Lusaka included. And we are providing that training and evaluation. The idea is that these non-physician health workers should be able to manage NCDs just as they also manage HIV, but in an integrated way. And so when you evaluate the impact of what we want to do is to look at what we are calling dual control. So we don't want just somebody controlled for HIV, but the NCD is not controlled. We are now aiming to have as an impact both HIV and whatever NCDs. So some have got just hypertension, that should be controlled too. And if they have got diabetes, all the three, HIV, hypertension, diabetes, should also be controlled. And so we are looking forward to providing these lessons to the ministry as the team seeks to expand this integration discussion, because we are doing research so we can do more to understand the processes, the costing of the same. And so we are doing a cost effectiveness analysis and also piloting the tools we are using, which can be used for M&E. So the study started about 2 years ago, and it's going to end in the next 3 years. And hopefully that CIDAS, UNZA, and the ministry could have a package that other countries in Africa can learn from. So let me stop there. So that's the study we call task pen, because we are task shifting the management of NCDs from clinicians and focusing on non-physician health workers, clinical officers, nurses, and also we are also grappling with the issue like what would the role be for community health workers and volunteers in these settings. Let me stop there, Dr. Mwemba and team. Thank you for inviting the task pen team. Dr. Mwemba, if you wanted to add something, you can please add. Let me stop here. Thank you very much.
Thank you so much. Okay, thank you so much, Dr. Mtale, for that elaborate, presentation and the role that we have to play. I'll allow Dr. Meg to just speak quickly before we get into the case. However, Dr. Mwamba, Dr. Mtale, Dr. Msiska, if you are able to attend to the questions that are in the chat box, that would be really helpful, even as the case is going on, because we're running out of time. So Dr. Meg, you can unmute and give your thoughts, and then we'll go straight into the case.
Great, thank you. Thanks everyone, and thanks for the presenters. So the point I wanted to make today is that, even though the ministry is taking a, phased approach to implementing the integration, just wanted to emphasize that, there are things that we can all do today to improve our NCD management and set ourselves up for success, right? And those are things like measuring the blood pressures and documenting them in SmartCare. That's also, goes for taking the weights and the height of people. So anthropometric measurements. So I think these are things that are already being done, but let's remember that all facilities with the capability to use SmartCare, we need to be collecting this information so that we know what the extent of the problem with hypertension, with obesity is that we're dealing with. Over, thank you.
Thank you so much, Dr. Meg. Thank you for that. Chilenge team, are we ready to do the case?
Yes, we are ready.
Okay. Are you able to share from your end?
Unfortunately, I can't share from my end, so I'm depending from that end.
Okay. Okay. No problem. We've got you.
Good afternoon. My name is Kambia Kwango Senga, a clinician from Chilenge General Hospital. So I'll present the case today. You can go to the next slide. Okay, so I'm presenting a female 54 who started ART on the 20th July 2015. Client came as a transient from State Lodge on the 13th of June 2022 and was on ABC 3TC EFV, and State Lodge had requested she should be switched to an appropriate regimen as EFV was phased out. So she was noted with high blood pressure, and she disclosed to be both a hypertensive and diabetic on medication. So the vitals at that day was weight at 5 kg, BP 204 over 123 mercury per meter, was 5, RBS was 17, and then there was no pallor, jaundice, no cyanosis noted. So the client was sent to casualty to be stabilized before going home, and was sent home in a BP profile. We can go to the next slide. On that same day, creatinine was ordered for, which came out to be 276.3 millimoles per liter. AST was 12.0, ALT was 14.1, bilirubin was 2.7, viral load, which was done on 25th January 2022, was 0 copies. RBS, which was done on the 13th of June 2022, it was 17.9 millimoles. We can go to the next slide. So that's, so the client was originally on ABC 3TC EFV, and we switched her on that same day to ABC 3TC DTG. We can go to the next slide. So our question was, how best can this client be managed? That was the question we came up for. I submit.
Okay, thank you so much, Chilenge, for that presentation. You've done it in about 5 to 6 minutes, which is really good timekeeping. So as a way to segue into a summary, Chilenge is presenting a middle-aged female who's been on treatment, HIV treatment, for about 7 years. She presented to the facility with a raised blood pressure, raised creatine, and is virally suppressed. So from the network, first of all, I'll ask if there are some people who are not very clear about the case and would like to ask a question or two to just clarify a couple of things. You can raise your hand if you want to clarify about the case. Chilenge is asking how best can they manage this patient.
Hi, Dr. Moma.
So please go ahead.
What was the heart rate for the client?
Chilenge, what was the heart rate for the client?
We skipped it on the presentation, but the heart rate was 115.
Okay, 115 beats per minute. Thank you. Isaac Tembo.
Okay, thank you. I just wanted to ask from Chilenge, what was the BMI for this client, if at all it was taken? And after she disclosed that she was hypertensive and diabetic, what was the medication that she was taken at the moment that she came from this clinical visit? I submit.
Thank you so much, Isaac. You're reading a lot of people's minds. They're asking about height.
Hello.
Go ahead.
Is it a medication for BP or ART? Which one does he need clarity on?
I think the first part is asking about the height. What is the BMI of the client? Because you didn't give us height.
I can't remember for the height for the client. Wow, I forgot that one.
What was your second part of the question, Isaac?
Yeah, my second part was when she disclosed she was hypertensive and diabetic and on medication, what exactly was this medication for hypertension and diabetes? I submit.
Okay, so she was on a number of medication. She was on Enalapril, she was taking Selma H, then she was taking metformin and Dawanel.
I think Dr. Agatha Lloyd is also asking the same question.
I think
because,
even the Medipine was there.
Yes, I was saying Dr. Lloyd is also asking the same question because it's very important to know not only the medication, but the dosage as well of what the client has been taking. Dr. Judith.
Good afternoon, Dr. Muhuma, and good afternoon, everybody, all the specialists and everybody. I just wanted to find out what were the abdominal findings on examination of this client. Thank you very much. I submit.
Okay, thank you so much, Dr. Judith, for that. Chilenge, do you have a response?
Yes, it was normal.
Okay. Okay, thank you. So, Chilenge, because you've asked how best we can manage this client, I think that's why a lot of people are asking all these questions that have to do with a lot of the history, a lot of the, the physical examination. Because if you go into the chat box, there are quite a number of questions that are being asked as well. Is there a family history of hypertension, for example? Does she have a family history of diabetes? Because all these play out in management of this client. Isaac goes on to ask further if there's any usage of alcohol, if there's tobacco use as well. Kelvin Shala, would you like to also clarify something?
Thank you, Doc. Maybe just to, I don't know if it is the right time to add something which I think in accordance to the question which has been asked by the—
Go ahead.
Thank you. So my first point would be, I'm looking at the weight of the client and I still see that this client is on the ABC regimen. I was thinking maybe we were supposed to actually switch this client to TLD or TAFED if possible. Then also, like everybody has mentioned, the history was not very rich, where we're supposed to have the family history and then look at other habits, like maybe even other maybe alcohol issues, if they are in there, so that maybe the counseling also, which could be something which will play a very major role in also controlling this situation, would be of help, where these clients need to be counseled on their lifestyle and maybe even the eating habits like we've learned. Then furthermore, I would also request for a chest x-ray just to check on the heart if it is enlarged, and also maybe to do other further investigations like the echo, maybe even the ECG, to just see how the client is actually working, how the heart is functioning. Thank you very much, Doc.
Thank you so much, Kelvin. I think Rose Chira has actually tried to respond to your query, Kelvin, and the others asking about switch to TLD. Rose is saying the patient has a high create CR, so maybe there's a possibility that there was some sort of kidney damage, and that's why the team has maintained the client on an ABC regimen. So, or indeed, we could switch to Tafed. Chilenge, do you have any response? So some of the things that I've mentioned are that, you know, the history, it would have been much more. Hello, Chilenge.
So the client doesn't take alcohol, doesn't smoke, and at the time we were switching her to ABC regimen. The creatinine clearance was below 50, but yes, it was below 30. In fact, it was about somewhere 20 something. So that's why we switched her to, and we tapered down the 3TC to a renal dose.
Lenja, are you still on the call? I think we've lost you, or you've lost me.
I was saying, are you able to get me?
Yes,
hello?
we're able to get you.
Yes, I was saying the client doesn't drink, she doesn't smoke, and at the time she came as a transient, her creatinine clearance was below 30. That's why we switched her to that regimen, and we tapered down the 3TC to the renal dose, which is 75.
Okay, thank you so much, Chilenge. Mutale Mulenga, you have your hand raised.
Yes, thank you so much. I wanted some clarity. Yes, I do understand the ABC regimen was due to the renal dysfunction that they might have assumed. So I'd like to find out if they did do a repeat renal function test, and also if they might have tried to do an abdominal ultrasound to try to figure out the extent of the renal dysfunction that this patient might have had. That's my question. Thank you.
Okay, thank you so much. Chilenge.
So we repeated, probably she came last week, so we repeat the last week she brought new result, which even showed that the creatinine further went down. So we ordered for the abdominal ultrasound, but we sent her to be reviewed in the medical clinic.
Okay, thank you so much. Do we have any other comments? So part of the management is obviously taking a detailed history, doing a full physical examination. Do we have any other comments from the network before we have our experts weigh in as well?
Doc, may I through lastly, maybe the reason why I'm trying to emphasize on the use of maybe Tafed, seeing that we do not have, seeing that the TLD could not work because of the kidney issues which we are suspected. Tafed would be helpful to this client, looking at the number of drugs this client is taking, because at least Tafed will just be one tablet, unlike the ABC, 3TC, then the DTG, unless if that facility will tell me that they've got a combination of just one tablet with the treatment they are using now. Thank you, Doc.
Thank you so much. So Brenda is asking what the latest creatinine clearance is. And one other comment from Mildred Kalenga is saying that the high creatinine levels and high blood sugar give us a sign that this patient may have diabetes leading to failing kidneys. It may be necessary to transition to TAFED or adjust dose of current drugs. Also advise on diet.
Hello, this is Challenge. So the latest creatinine result was 166.9, which was done on the 4th of August 20. Oh, no, sorry. Yeah, do I have that one? We didn't record it. Okay. We didn't.
Yes, Challenge.
We didn't record the latest creatinine result, unfortunately.
Okay, yeah, although what they're asking is about, creatinine clearance. I know Dr. Mwenya Lungwebungu from Challenge is saying kindly comment on use of TAFED with creatinine clearance of 28 initially, and now even lower than 28. Richard Watala from Western Province, one of the HIV TB mentors, is saying TAFED may be problematic if the creatinine clearance is below 30. I hope we're taking note of those comments. Okay, at this point, I'd like to invite some of the experts that we have on the call to just give guidance to the Challenge team. I'd like to start with Dr. Sophia Msiska from PHO. Dr. Sophia.
Good afternoon, team. Thank you very much, Dr. Muhuma. Unfortunately, I cannot comment at the moment. I'm with some people in the office. So if you could ask the other experts to comment, I see how I can finish up here. Thank you.
Thank you so much, Dr. Msiska. We know that yours is a very busy office. Thank you for acknowledging. Has Dr. Sivile joined the call? Dr. Daniel Mwamba, are you able to give a few pointers for the Challenge team? Okay, Dr. Mwemba.
Thank you. If I can just comment, I know we don't have enough time, but I'll just go through quickly. So there are issues here. There's HIV. There are two NCDs, a high sugar and a high BP, actually three with a what seems to be renal dysfunction. I think a quick calculation for myself with the creatine that has been given there, it looks like the estimated glomerular filtration rate was around 19, What we don't know is whether the kidney is the one that is causing the BP to go up, or the BP is the one that is causing the creatine to go up. So we need to answer that question. I think that is a complex case for Chilenge. So that's my first input, that maybe you need to refer it to us so that we can manage it for you, and then we can refer this patient back to you. But obviously the principles of management is that we need to optimize her ART. And I know that someone has, what we will do is that someone has mentioned Tafade. We can give Tafade even below 30. But this has to be given by an expert. And so we don't encourage another person to just adjust the dose for Tafade. So I think that we'll obviously give the Tafade and see whether the patient can tolerate Tafade. Obviously, we need to ensure that the CD4 and viral load is well suppressed in this particular case. Would have loved to have done her urine protein because she's a diabetic and sugar was high. So we want to know whether this kidney disease is related to the diabetes as well, and therefore a urine protein would be very helpful in this patient. Since the eGFR is less than 30, I think metformin has to be stopped because metformin below 30 cannot be given in a diabetic patient. We don't have an option of a GLP agonist for the sugar. And therefore, if the sugar is not well controlled, I think insulin might be the best option for this time until we know where the kidney, whether this is acute or is chronic. What else did I point out? The BP is very high at the moment. And maybe if we control that BP very well, the kidney function might actually improve because this could just be malignant hypertension that is causing the kidney not to work very well. So good management of the BP will be very good, and maybe the kidney function might get better. And that's why I'm saying maybe it would be nice that we manage this patient and then send her back to you. So I've talked about HIV management. I have talked about the sugar management, that we need to stop the metformin. We might need to review some of the drugs she's also taking. For example, you said she's on Telma H, so the H part might not be good because the eGFR is low as well. And then we obviously need to do her lipids to see whether the lipids are high, because usually people with kidney disease, they also have high lipids, and those with sugar also have high lipids. So it would be nice to just check the lipids to see how they are. I think those will be my inputs for now.
Noted.
Thank you so much. Thank you so much, Dr. Mwemba. And I think the Chilenge team has taken note. What's coming out is that this is sort of a specialist case. So Chilenge team, you do well to send this client over to UTH. I think that's the nearest for you. Then, but the principles of management have been outlined very well. So what we need to do, even as other facilities, we need to learn from this case that we can manage HIV, NCDs together, but also when we need to reach out to the experts, we should quickly do that, especially when we see that this is a person who's been on a cocktail of drugs and they seem to not be responding in one respect or another. They might be suppressed, but they've got all these other things going on. So it would be good for Chilenge to send this patient to UTH.
Noted.
Okay. So thank you so much. We just have about a minute to 4 o'clock. So let me just go through the chat box once again, just to see if there are any burning questions that. Okay, so Mutale Mlenga is asking, Dr. Mwemba, Mutale is asking, what is the comment on the use of, DTG or ATV for CKD patients? Can you just give a comment on that?
So DTG or atazanava?
For CKD patients.
Yeah, there's no contraindication on whatever. Obviously, DTG is just an interaction with metformin that you need to be very careful. So as you escalate the metformin, you might not want to go beyond a certain more than 1 gram if you're using DTG, but otherwise you can use it. In a diabetic, obviously most of the CKD patients are diabetics, and so if they are gaining too much weight, there's a chance that they might have worsening of sugar because they are using DTG. So there's no contraindication for DTG and kidney disease. There's also no contraindication of atazanava and kidney disease. So I would use them if there's need for me to use them. Actually, I think that I wish Dr. Sivile was here. I think that in the guideline, we are actually probably promoting that for those patients that cannot be on tenofovir, one of the regimens that we might use is DTG plus a PI, which PI might be atazanava in this particular case. So there's no contraindication, so they can be used.
Okay, thank you so much for that submission, Dr. Mwemba. It has been a good session, at least according to me, and I hope the network found it very useful and timely, especially now that we are trying to integrate these services more. So we were looking at NCDs in people living with HIV, and we will share the presentation immediately after this session is closed. So I was your facilitator, Malilwe Muhuma, HIV TB medical officer with the Lusaka Provincial Health Office. With that, I think we can close this meeting at this point. So thank you for your attention and thank you for your attendance.
Bye, thank you.
Bye, thank you.
Thank you. Thank you. I'm Sanukwa.
Thank you very much.
Thank you.
Thank you. Congratulations to the team.
Kote, may you please assist with dropping participants who may be struggling to leave the meeting?
Yes, Dr. PLHIV, we've been assisting those who are currently remaining. It's a bit of a slow process, so please bear with us.
Hi, Dr. Sombo.
Oh, hi, Kote. I see we are. We've lost Muhao. Is Muhao still in the hub?
Dr. Sombo, who is Muhao?
Yeah, Muhuma. I'm so sorry. Even sending that email, I always send to wrong people. How are you? How are you?
I'm good, thanks. How are you?
So now you guys able to switch on your camera. Brian has his camera on. Okay.
Hey everyone, this is Brian. I lost Dr. Sambo's audio. Can you still hear Dr. Sambo?
I can't hear her.
No, Dr. PLHIV, we may have lost your audio there. Oh, we may have lost her.
Yeah, she's just dropped off, so wait for her to join.
Yeah, sounds good. And for those of you I haven't met, my name is Brian Wood. It's a real pleasure, honor to work with you, join the session today. I work for Project ECHO in University of Washington and University of New Mexico, though I'm currently living in Lusaka. And so I'm here simply to observe, chat with you briefly about what challenges you're feeling with your sessions and just help brainstorm some, potentially simple things to address those challenges. So that's my role here.
Yeah, sorry, I dropped off. Yeah, continue, Kote. Sorry, I dropped off. I see Thomas Banda from Petauke has joined the session. Okay. Brian, do you want to just jump into it in the interest of time? It's 12:04.
Yeah, sounds good. We can keep pretty efficient. Can I just ask, before I tell you a couple of observations, can I just ask you each really quickly, what are you feeling in a couple words are the biggest challenges? Either today's session or in general, all of your sessions in the program, what would you say are the biggest challenges? Like Dr. Muhuma, what would you say?
Well, today, this is Kote speaking.
Kote.
Yeah, so Yeah, today we had a pretty smooth session as far as, well, the facilitation and the presenters going. But again, I'm going to sound like a broken record. We really need to upgrade the equipment that we have in the hub. The facilitator's computer somehow miraculously runs out of network, even when we have perfectly functional internet. So
gotcha.
Yeah,
it's a challenge. Yeah, thanks for sharing that. Other challenges that come to mind that you felt today or overall? Well, I know we want to be efficient here. I'll give a few observations and maybe I can ask for your reflections. Honestly, I thought the session was excellent. I thought it was very strong. You clearly have a strong team, a strong community, and have built a really strong program. I participated in a lot of ECHO sessions, and there was a ton that I thought went really well today. Clearly, the IT team is on top of it. You had slides shared without, having to fuss around or mess with them. You were muting people who needed to be muted. The timekeeping at the end, I thought was really excellent. I really thought the facilitation was excellent too. Dr. Muhuma, I found you to be very calm, collected, approachable, and you were managing a lot. When you have 300 to 400 participants, plus the chat box, plus a didactic that was longer than you expected or wanted, it is a lot to manage. And I have facilitated sessions and it is tough. So I really think you have a really strong program here, and it was a very, very strong session. I have a couple ideas to consider, only ideas. One is, so I really like that you started on time. I see a lot of sessions that don't, and you did a really good job of welcoming people, about 3 minutes in. If you could even jump in 10 minutes before the session and start checking in with people, sound checking, see if your experts are there, maybe even prepare folks about what's coming and see if you can plant the idea for a question or two, or give a site or two, the idea that, maybe you'll want them to share what they're dealing with. That 10 minutes before the session can be valuable. So just something to consider and try. I really, really liked the way you used the knowledge polls as check-ins. I thought that was really skillfully done. One thing you might consider to encourage discussion and interaction would be some polls that are not knowledge quizzes, but polls that ask people what they are dealing with in their clinical sites, wherever they are, their hospital or clinics. For example, today, you could do this in the chat box, you could do it with WhatsApp, you could do it with a Zoom poll. You could ask, what is the most common NCD you see in your practice? What is the biggest barrier in your site to integrating NCD and HIV care? I think those sorts of things really help to stimulate discussion. And I think you have an innate challenge with 300 to 400 participants of, keeping everyone engaged and getting them interacting. So I wondered about other ways to stimulate discussion and get people to think about in their small groups or in their small teams or with their local clinical mentors. So some, not necessarily knowledge polls, but sort of discussion stimulating, sharing polls also can help you as a facilitator, because then, you say, what's the most common barrier you see? And then you see the most common one, and then you can ask sites, okay, please share a little bit more about that. Why do you see that's a barrier? And what have you tried to overcome that? So again, just something to consider. And then, the other thing I was wondering if it might be useful would be, as you sort of tried to do, Dr. Muhuma, is assign somebody to monitor the chat box and both keep track for you and respond to some of the questions, because it is a lot on you as a facilitator to try to do both. So you could set as an expectation that one of your experts each session keeps an eye on the chat box, keeps an eye on questions. There were a couple questions that kind of got buried in there, and then responds to the simple ones as they can. It might take some of the pressure off of you. So those are maybe 3 things I might consider trying. Use that opening 10 minutes before the session, some discussion stimulating polling questions or chat box questions or WhatsApp questions, and then assigning somebody to help keep an eye and respond to the chat box. But honestly, I think it was a very strong session. So those are my observations and some ideas, simply ideas to try. maybe I can just ask you your reflections on that.
Okay, thank you so much, Brian, for those comments. And indeed, it's very important what you've said. We need to definitely do sound check just about 10 minutes before, and then try to engage the participants, because sometimes we are even better today that we managed to finish on time, but there are some times that we go a little bit overboard because there's a lot of material that we have to cover and the like. And I think what you've said is really helpful. We will try even next week. I think I'm facilitating again the session for next week. So we will try to implement some of those. And I know that the ECHO coordinator is on the call at Tambuyu. So that one for the poll questions that do not only check the knowledge, but also check what other issues that the participants might be facing is probably a good idea as well. Only that we will probably have to narrow it to maybe random facilities, for example, because it would be difficult, as you've said, to just put it out there. What challenges are you facing? We will have 30 answers, 40 answers, and we'll be unable to get down to them. So I feel like we may just randomly maybe choose a facility to say in a couple of minutes what challenges they might be facing. So for example, the session for today, one of the facilities would talk about which NCDs they commonly see, and then what are some of the barriers, as you've rightly pointed out. And yes, keeping an eye on the chat box, it's quite a lot, especially when you are trying to read out a question. There's another question that comes in, and there's a hand that is raised. So there's a lot that is going on. But I think the IT team is doing a fantastic job so far, because they sort of also in the background, I know people can't see it, but they do remind the facilitator in case you forget something, because it can be quite overwhelming when you have a lot of things to do. And you're trying to look at your time, look at how much more of the presentation is left, the challenges that come with that. So yes, I agree that we can have somebody that can be probably checking on the chat box from time to time.
Recording in progress.
Okay, sorry, the computer I'm using, I dropped off. I think that's one of the challenges that IT mentioned. So as I was saying, yes, it's definitely a great idea for someone to keep an eye on the chat box. And during the presentations, when I'm facilitating, I try to encourage other experts that are unable to come in and other people that are knowledgeable. So definitely that is something that I try to do, and other facilitators I've seen also try to do the same. Check the chat box, somebody to handle those questions. So I like your ideas, and because I am also doing the next session. So these are some things that we can probably try to do. But I'd also like to get a word, I guess, from Etambuyu, who is the current coordinator, what she thinks about these ideas.
Hi, everyone. Hi, Dr. Moma. Hi, Brian. I like the ideas as well. Though I'm thinking the challenge would be on time. So maybe we should just stick to one. Let's say if we adopt the idea of using 4 questions that are general, that we want to get maybe ideas or any non-specific answers from the facilities. I'm thinking we can try to use them either before the actual presentation starts, more like a reflection. It comes like a reflection in the presentation, or at the end. Actually, the didactic presenter for today had put in 2 reflective questions at the end. But looking at time, I think we didn't even have time to reflect on those questions, but there were 2 questions at the end. So I'm thinking, if we're using poll questions for that session, if we decide we use poll questions, we can use the poll questions, which would want with specific answers, or maybe if you want reflective questions, or just getting the general idea, or what's the current experience from that facility, we can adopt those, but either immediately after the presentation or right before the presentation starts. You just maybe, like you said, you gave an example. Maybe you tell them to give an example of an NCD, the common NCD they have at the facility, and then just one facility. Because remember, we had 400 connections. So if it becomes so general, maybe 100 will respond with problems, which should be hectic. Then for checking in the chat box, yes, as a coordinator, it's just unfortunate that I'm on leave. I was joining from home, but we do check as coordinators in the chat box, but the challenge comes in to respond to most of the questions. Quite all right, you can check and alert the facilitator, but we are not content experts in certain fields. So I agree with you, Dr. Brian. I think it's important for the facilitator to identify one expert at the beginning of the session who can help respond to some of the questions. Actually, I think 2 or 3 echo sessions last month, there were so many questions that went unanswered that people were pissed. They were not very happy, the participants. Like most of their questions were not addressed, and it forfeited the whole purpose of our echo session. Anyway, the other reason could be because of time. Certain topics are very interesting, really. And then you have an overload of questions, and then the facilitator will be overwhelmed, the didactic presenter will be overwhelmed, time will not accommodate. So I think it's wise that we should just train all the panel of experts to be helping. Actually, it should be a habit we should adopt. At the beginning of every session, we encourage them, remind them that they should also be addressing most of the questions in the chat box, so that we relieve that pressure on the facilitator as well as the didactic presenter. Otherwise, it's a learning phase. I'm sure next week we'll do better, since Dr. Muhuma will still be the facilitator and I'll be there in person to do the coordination. Over to you, Dr. Brown.
Excuse me, let me just say thank you, Etembuyu, for sharing those things and for those ideas. I think those are really excellent points. I will just add quickly, time is really challenging. It is difficult to manage time with a didactic, allowing everyone, your expert panel, plus the community to have a chance to ask questions, and then the case. Once you did the case presentation, you got such great interaction, though. That was really great to see. You had a lot of people chiming in. So clearly it's a community that's very interested. I do think, and I've experienced this, it's very challenging when you tell a didactic speaker, okay, you have 15 to 20 minutes to talk, and then they send 60, 70, 80 slides, and they talk for 40 minutes. So I do think another thing I would keep in mind is, for example, with today's didactic, it might have been a great opportunity to split that into 2 talks. It could have been 1 talk on the, maybe it could have been 3 talks, an epi of NCDs and HIV. What is integration? What does it look like? What are the challenges and solutions? And then what is the common treatment for the NCDs? Really, it could have been 3 15-minute talks. So I would maybe just think when you get a lot of slides like that, okay, how are we going to split this up? How are we really going to keep the time in check and give your speakers very clear expectations ahead of time, which you may already do, because time definitely is challenging. The other thing, I really love the idea of asking a site to share. If you're going to do that, I would prepare them ahead of time, so you're not just putting them on the spot. Tell them either by email or text beforehand, or in that 10 to 15 minutes beforehand, if there's a site you think would be good to share, just hey, FYI, we're going to ask you to share, so they're not put on the spot. That gives them a little bit of time to prepare, and I think you'll get better comments and participation that way. The other thing, if you're going to do a poll for discussion, is you could still do a multiple choice question. You could say, if you can think of the common answers, so, what do you think are the common barriers? What do you think is the biggest barrier to integration of NCD care and HIV care in your system? And then you could list what you think are the 5 most common. and then ask people that way. So you're not getting 100 answers, but you're really seeing what people see as the biggest barrier. Again, this is just food for thought and things to consider. I think with 300, 400 participants, it is challenging to just keep everybody engaged, but you had great interaction, and really, I think it was a very strong session. So I'm presenting ideas only to take what is a strong program and strong session and try to make it a little bit stronger, that's all. But I will submit there.
Hi, Brian. Do you think you hand in that the feedback form to us, or we just let it and we'll take notes?
Either one is fine with me. I'm happy to write up a summary and send it to you.
Yeah, I think that would be very helpful, and I agree. I need to mention this because Muhuma is naturally a very, very good facilitator. And I mean, that's very easy to pick. And I appreciate the feedback that you have given us, particularly the second one on just facility-based experiences. I think we'll go with turning them into polls just because it's easier to manage and putting in a few questions. I think that's a brilliant suggestion, because that one we definitely have not done. Unless there's anything else, I think we appreciate that feedback. Muhuma, thank you so much for that great session. I think I gave IT my feedback in terms of the blurry background in the hub. That doesn't look nice for a hub, but I think there are a lot of people coming in and out. So maybe, Kote, can we consider maybe moving where the facilitator sits to somewhere where they don't have the people moving? Do you think that can work?
Dr. Polishi, the positioning of the presenter right now was how can I put it, temporary. We will be moving, we will be making the hub more presenter friendly going forward. It was just a stopgap while we were trying to get our place ready here. As you know, we've only just moved to this location.
Okay, I think that's noted. I think that feedback has been noted by all of us. And Brian, we really appreciate your time.
It's a pleasure. Honestly, it was a really great session and honored to be a part of it. So thank you.
Dr. Pelosi.
Oh, excuse me.
Oh, no, please, Brian, go ahead. I'll ask later.
I will write a summary and get it to you probably tomorrow.
Okay, thank you. Dr. Foloshi, I also wanted to suggest, or rather ask, is it okay if we can be including Brian in our emails? Like when we're sending the invites, when we are preparing for the prep meetings, is it okay to invite him also for the prep meetings? The Zoom preparatory meetings that we do for the
I had a
sessions?
meeting with Kunda this morning, and Brian, there were three of us. I think she noted that, I think she took note of his email so that she can be looping him in to everything we do. Of course, he has a very busy schedule, so what he can join in, he will join. Where he can't, we'll just see that Brian hasn't joined. I think Kunda has the details, so you can work with her to make sure he's in all, we add him to all the mailing lists.
Noted, thank you.
Sounds great.
Yeah, it's 4:30, so I'm sure people want to get moving, traffic. Thank you all for this, and thanks, Brian, thanks, Muhuma, thanks, Eta and Kunda.
Pleasure. Thank you all. Have a great evening.
Thank you. Have a great evening.